Good morning, everyone. We'll start. Thank you. Good morning. Welcome to this board meeting. I'm just going to ask everyone to report back on their 15 steps. But before I do that, a quick announcement. You'll see a new face around the board table. Dr. Chris Elliott, he may well be known to many of you. He's been a GP in Sutton, Belmont, in both, well, for many, many years. I think he just recently stepped down from clinical practice. Is that correct, Chris? Yes. And as you may know, we have been developing our links with community care, and we're going to be looking after an organisation called IDEA, which stands for the Integrated Dorking, Elmbridge and Epsom Alliance. There we are. Integrated Dorking, Elmbridge and Epsom Alliance. It's community-facing, which is going to deliver the sort of Epsom health and care message throughout that whole area. And we've also now developed Sutton Health and Care, which will be starting later this year and will be taking over the community service from April 1st next year. So we felt it very important that we had a non-executive director on our board who is very familiar with community care, with primary care, to essentially be able to link into that area, very importantly for us. And Chris has been appointed as an associate non-exec director, and he'll chair the IDEA board and the Sutton Health and Care boards, and will also come to our board meetings, so that gives a good link into, if you like, to the trust committee structure. So welcome to Chris. And it's also the final board meeting for two of our exec directors, Charlotte Hall, our Director of Nursing, who has been with us for 3.25, possibly even 3 1/3 years, is retiring. And so she's giving up her badge and her PIN number and going to do other things. So a huge thank you from me and also from the board to Charlotte for her great work and great service, not just to us over the last 3 1/3 years, but to the NHS for 38 years as a nurse. So thank you very much, Charlotte. And yes, thank you very much, Charlotte. And it's also the last board meeting, although he's not leaving today. Kevin Croft, our Director of HR. Kevin, I think, is the longest serving exec director. It's been, 7 years? 7 years, so that's a really long stint in NHS terms. In fact, it's a marathon, really. And Kevin is going to become the HR Director of Imperial, a very large trust, and a brilliant promotion for you, Kevin, and the best of luck with it. Kevin actually leaves us at the end of July, but he'll be on leave for our next board meeting. So this is Kevin's last board with us. So congratulations to Kevin, and once again, many thanks for all that you've done for us. So I'd now like to talk about the 15 Steps Challenge. I have a list of where everybody went, and the first person on the list is, it's me and Peter. And we've just been to M2, which is just over there. It's the gynae ward, gynecology ward, both for day cases and for inpatients. And we also had the pleasure of bumping into Dr. Croucher, which is always a challenge in many ways, because she's quite frank about some of the issues that they face, and that's very good for us. And also we saw Marianne Lukey, who is the Director of Midwifery, so we had a jolly good discussion about some of the issues facing our gynae ward, and I think they are very much the same that face the hospital at the moment. It's a ward where the staff do a great job, but it's not designed appropriately. So there's only one lift, it's in the wrong place, there's no place for a nurse's station. All the basics in terms of how a ward should be laid out aren't aren't in place. Having said that, we had a good discussion with the doctors looking at the whiteboard, seeing who's actually in there, and it does seem that most people are only in there for 2 or 3 days, which is great. There was unfortunately one lady who's been there for more than 50 days. And the reason for that is that they cannot get the package of care sorted out so she can move on. And it's something they're working very hard at, but she's been in for 50 days, which is a huge amount of time, and she's medically fit to go. So that's something that we and many other acute trusts suffer from all over the place. But we talked to patients, and I talked to a nice lady who came in, and this is perhaps a more typical situation. She came in on Wednesday evening, she had her operation on Thursday morning, and she's being discharged today. And she was very, very fulsome in her praise, and she said it was a really good experience. Everyone been very kind, and she'll be off today, so it's how it should be. So Peter, have you got anything else you'd like to add?
So I think the key element that I took away was that everyone we spoke to was really positive about the care and the speed with which they were being seen. The big challenge was those who'd come in for a day case procedure today. There was nowhere for them to wait properly, so there weren't even enough chairs in the corridor, which is what our temporary arrangement is to enable them to sort of be prepared, sort of psychologically prepared for what's the procedure that's ahead. So the teams were busy trying to make arrangements for them to be seen and prepped accordingly, but those just waiting were sort of stuck in the corridor. So that was clearly a consequence of the pressure of flow, and but also some of the layout issues that you've talked about, Lawrence.
Right. Pat and Rakesh.
Yes, we went to pathology, which is on 3 floors in D block. The first floor is all pathology testing, haematology and so forth. The thing that struck us most, I think, was how incredibly congested the area was, and also the quite a continuous low-level noise, which personally I would find quite difficult to work with in a cramped area with not very tall ceilings. But the staff were universally cheerful and enthusiastic about what they do, and they clearly are working very hard. The activity is going up. There are some challenges from the new accreditation process, which they have to do on top of their day job, which has created quite a lot of pressure. And the only thing that was mentioned as a challenge to them was the staffing and dealing with these new requirements from the regulator. We then went up a floor and we saw the neonatal testing unit, which was quite different. It was much airier, lighter, brighter, but with the same levels of enthusiasm from the staff, and grateful, I think, to Rakesh for a new machine that they're expecting, which will enable them to do tests. This is tests on newborns, the HEAL test, which we do for a very wide range of trusts around the country. So what I took away from it was that this is a very well-run, enthusiastic staffed service, which works in some parts in rooms that are really quite pleasant, but in large parts in rooms that are really quite a challenge for your working day to spend your 8 hours or your 10 hours in there.
Thank you very much. So Richard and James, you went to A6.
James, do you want to kick off? Thanks, Richard. So A6 is a care of the elderly ward, which is a female ward, but we stopped off on the way up the stairs to gather our breath on A5 ward, which is the male care of the elderly ward. And I think the wards have a challenging layout, so it's quite difficult to avoid a sense of clutter. But we spent some time looking at the whiteboards. There were whiteboard rounds just about to start on A5, which were very multidisciplinary, including the medical staff. And the sister was right on top of absolutely everything with absolutely every patient. And she was really very keen to tell us about all the discharges that had happened last week and this week and were planned for the following week. We looked at the whiteboards in terms of the VTE assessments, which has been a challenge for the Trust. And on A5 ward, all but one VTE assessment had been completed. The one that hadn't been completed was a patient who had been transferred there yesterday, and the sister knew all about that and said that would be completed at the whiteboard round this morning. And I think we were left with a sense of confidence that that was a ward that was very well run and very tightly managed. We then went on to up the stairs to A6 ward, and there was a little bit of a contrast, to be frank. There was more clutter. It may just have been that deliveries had just happened on the ward, but it didn't have the same sense of optimism. We looked at the staffing levels and the nursing levels. The total numbers of nurses were correct for the establishment, but the skill mix was slightly down. So they were short of one trained staff, and but they had an additional healthcare assistant to support the team. But there seemed to be a less sense of combined working between the medical staff and the nursing staff. The consultant came onto the ward as we were on the ward, and had a conversation with Richard, and I'm sure Richard will relay some of the consultant's observations about the challenges he feels that he faces looking after the patients there. Whilst Richard was talking with the consultant, I had a conversation with one of the patients who actually reported that she had a very positive experience being looked after on the ward. She felt the care was very good. She was aware of what the discharge plan was for the following week, and she felt that she'd been involved in the decision making. It was quite a busy time of day. There was an outlying medical team who'd come to see a patient. So there were lots of hustle and bustle at the time that we were there, but I'll hand over to Richard.
Thanks, James. Yeah, I mean, I guess one observation was when looking at the whiteboards, the length of stay on A6 seemed materially longer across many patients compared with that on A5. Now that may be for good medical reasons, but you've got two very similar wards with very different patterns of length of stay. So in speaking to the consultant, I guess there were three aspects that he referred to. First of all, he tended to refer to his own notes rather than using the whiteboard, which I thought was interesting. But he identified a number of patients off his list who he said are medically fit for discharge, but for whom there was no care package available, therefore they remained on the ward and were therefore at risk associated with not getting the right level of physio or potentially suffering from pressure sores. He was of the view that there was a shortage of nursing. Now again, I'm not quite sure what the ratio of nurse to patients is between A5 and A6, but in his view there was a shortage of nurses. And he also felt that there was an issue with culture, as he put it, but it was a relatively broad statement, and we didn't get the opportunity to delve into more detail around that. I think just my observation was two very different sets of observations on two wards, which in many ways are operating a very similar profile.
Yes, thank you. It's very interesting, and it seems the sort of thing that we could perhaps in the fullness of time dig into a little bit further the differences.
So I think it's the observation comparing the two wards is very interesting, because on the face of it, we ought to be offering something that is a little bit more consistent across wards where essentially the nature of the patients have the same care and medical problems. So I think we've got some ongoing work to do to look at some of that variation in practice and to explore some of the concerns that the consultant has to see what's valid, what we should change, and where we should alter our individual practice to meet the needs of the patients.
Thank you, James. So next is Ruth and Daniel.
It's actually Ruth and Charlotte. So
Oh, it's Ruth and Charlotte. It just said Daniel question mark.
Should I start? We went to ward A3, which is a ward looking after patients who have orthogeriatric needs. So essentially, most patients fractured neck of femur. I think the comments about the layout from other wards replicated on A3, and that one walks into what can seem like quite a cluttered environment because there's a lot of equipment, because there's a lot of rehabilitation takes place on the ward, and it does create the impression of clutter as you walk into the door. However, the ward was very calm. We were greeted very warmly. There was a lot going on. There was a medicines round going on. There was a huddle going on. The senior staff were out and about, as one would expect at that time in the morning. We had the opportunity to talk both to staff and patients. Staff actually reported to us that they were very well staffed and felt very well supported. They didn't flag any major issues at all. And were looking forward to the shift ahead of them, which was very positive to hear. And then we went on to have a further look around the ward and chat with the patient. So Charlotte, I'm sure, will want to say more.
And the patient had a lot of good things to say about the care. She actually talked about her wartime experiences and the underground rivers of London, which was very interesting. And for me, it was very interesting to see the ice pod. So the CCG funded 2 years ago, I think, for us, a new side room system that you plonk into a ward and it creates a side ward. And it was good to see it in practice, actually. And the patient seemed very happy in there because it's very easy to look out because it's all glass. So yes, it's a good experience.
And I think just one more comment to say that the whiteboard was beautifully kept. And once again, we saw all bar one of the VTE assessments had been undertaken, and actually all the observations bar one were being acted upon in a timely way. So it was great to see the board in use, and the staff there actually reiterated how helpful they found the board. I think because they are predominantly a team based on a ward, and I think where the team are based on one ward, the whiteboard actually is optimally used. So they spoke very positively about it.
Thank you very much, Ruth and Charlotte. So, Elizabeth and Trevor.
Yes, thank you very much, Lawrence. We went to visit Richard Bright Ward, which is the renal dialysis inpatient ward. So the people who, it's a very different ward from most of the other places in the hospital, because these are people who use the facilities a great deal. So they're all very well known to the staff, and in fact the sister in charge described it as very much having a family atmosphere. She's been there 10 years, Sister Susan, and she is running a very cohesive and stable team. The ward is currently in porter cabins sort of down on the far corner. Obviously, James, this was originally intended to be a short-term facility, wasn't it?
Like my office, Elizabeth.
Yeah, thanks, James. And it was clearly also developed when we weren't providing this service to nearly the same number of people. To call it cramped would be an understatement. However, I was with Trevor, and he was delighted to tell me about the progress on the front where we are shortly going to be relocating this entire service, and I'm sure he'll want to tell you a little bit about that. We did speak to some of the patients. We also spoke to a number of members of staff, and one of their frustrations is that because they are such a cohesive team and very stable, they are sometimes asked to go and support another ward which is short-staffed. And they're very skilled in looking after renal patients, but they find that transition very difficult. And they sort of were saying, well, they feel rather useless sometimes when they turn up on another ward because it's difficult for them to transition their particular skill base. Another point that came across loud and clear is that when somebody comes in for dialysis, the outpatient dialysis people come in 3 times a week for 4 hours a time, and they are hooked up to a machine. And it must be so boring for them. We don't have Wi-Fi on the ward for them to log into. There are some television screens that they might possibly be able to watch, but apparently at surge times, like when there's the World Cup or Wimbledon, tempers get a bit frayed who has the right to see what and what should be shown. And I think that one of the takeaways is to make sure we involve people in the design of the new facility so that we can make it as helpful a patient experience as possible, because we're giving the great clinical care, but we also have to think about that side of it.
No, I think it's important that it's something that we have been looking at in terms of we provide Wi-Fi for the unit, but it's not free. I think that's something that we've got to try as a trust to try and to work through. How can we actually provide free Wi-Fi for patients? That's very important. We are very important that I think we are looking at hopefully by December having the new dialysis unit at the front of the hospital, and I think that's really important that we've got to look at what the patient entertainment facilities around that, and we'll make sure we pick up that facility as well. But I think from my observation, it was a very friendly ward, and it was very cluttered, but they were doing the best they could in that environment.
Thank you. So finally, I think it's Martin and Arlene who went to the nursery.
Yeah, so this is the nursery for the children of staff, and they take from babies to when they start school. And of course that's incredibly important in terms of both recruitment and retention of staff, and also our equality, diversity and inclusion. In short, it's a very it's very impressive, very happy atmosphere. Staff are obviously passionately committed to what they do and enjoy what they do, with a very long service and relatively few staffing problems, both the permanent and the bank. But unfortunately, in terms of recruitment, there is a waiting list, which I would guess must be a problem in terms of particularly recruiting from where there's other hospitals and they have children already in the nursery there. If there's a waiting list, and it's around half the cost of what it would be if you had to go into the private sector. The other thing is a familiar story. The building is not all it might be. It's it again is a temporary building which has been way over the expected lifetime, and it particularly manifests itself in being very hot in the summer and very cold in the winter, which is obviously difficult for the staff, but probably even more so for the children, particularly babies. But you know, fantastic facility, very impressed, and it was a delight meeting both the staff and of course the children. Arlene.
Yeah, I think I was quite impressed by how happy everybody was. And little Owen, that kept showing us his tummy, and he wouldn't go, he didn't want us to go, he just kept showing us his tummy. And he was very happy, and all the kids are very happy there. The space outside, I think, is also really, really great. They have really nice space where the kids could go out and play, and they do that independent, accommodation independently and managed. Overall, I think if the environment was better, it would be even better for them. But they are doing a fantastic job with what they've got.
Thank you very much, Arlene, and thanks everybody for going around. One of the interesting things for me was that when we went to M2, I think it was Marion who said, "I thought you were meant to tell us when you were coming," and we did remind her that we changed that process about three sessions ago. So it's very good to do it unannounced, I think, because it does, you just see what is there. Good. So on to the formal meeting. So welcome everybody. And
Is it possible to know what you do with this data? You have a lot of people who spend a lot of time seriously looking at stuff. What do you do with it?
Oh, well, all the things that are raised will be taken away by the appropriate executive and dealt with. So in the past, we've, for example, noted that, let's say, a drug trolley hasn't been locked up, or that something is broken or whatever, and so the appropriate exec will take that away and it will get dealt with immediately. So that's what we do with it. So we act on it, on all of this.
I was a bit concerned about 50 days.
That's unfortunately, it's an NHS-wide issue in terms of discharge, and it's something that will be addressed by the NHS as we get some more money. I'll be talking about that in a minute. Right. Apologies for absence.
Looks a pretty full house to me.
Yes, I think it is. It is a pretty full house, and it's very good. Are there any declarations of interest which changed from last time? Chris, obviously you'll have to fill in your declarations of interest form as appropriate, and we'll publish that when that's done. Good. So minutes of the previous meeting. So we'll just quickly whiz through those. So are there any comments from any directors on page 1, page 2, page 3, page 4, and 5? Good. So we'll move on to the action log once I can get this thing to work, which is, no. Yes, all right, I've got it. Thank you, Ruth. Okay. Action log. There's one action. An update on the staff bank.
Yes, so it's still progressing, and we're expanding the number of wards that are involved. I haven't got sort of actual numbers of how many staff have come from which areas, but we haven't had any technical issues since we went live, and we're just rolling it out as we plan to, really.
Good, thank you. So on to the chairman's update, and I just want to really mention a couple of things which I'm sure you will have, many of you will have seen in the papers, but which are very important for us. The first is, of course, the very welcome news that they've removed the visa cap on for NHS staff, which is really important for us and indeed all acute hospitals. It means that we will be able to recruit far more easily and readily doctors and nurses from overseas than we could when there was the visa cap. It was a hugely bureaucratic and time-consuming exercise to get visas for NHS staff, and I think it's a very welcome move for us and indeed for all NHS trusts. So that's a very important step. The other thing I wanted to mention was that you'll no doubt have seen in the press that there will be announcements soon, and possibly as early as next week, about a new financial settlement for the NHS. I mean, various figures have been bandied around, but there will be as we understand it, announcements of new money, both for capital and for revenue. They're not going to say who's going to get how much money. It'll just be, I think, at this stage, a big pot, and obviously I think there are still fairly serious negotiations going on between Department of Health and Social Care and the Treasury. But once again, it's very welcome. We will obviously need every penny we can get, as will all trusts, but I think it does demonstrate a recognition, perhaps belatedly by the government, that with demand for the NHS increasing at 4 or 5% a year, you have to put more money into it. So that's very important as well. The third thing I wanted to just bring out was something which is a little bit probably of real interest to people who work in the NHS, is that they are thinking about reorganising the top end of the NHS. So that at the moment we have two regulators. There's NHS Improvement, who are our regulator, who look after all the trusts, and then there's NHS England, which essentially sets all the policy. That's where Simon Stevens and his friends work, and it's also the organisation that relates to the CCGs and therefore to primary care. And I think there's a move to bring together the leadership of NHS England and NHS Improvement into one cohesive whole, and that work is also ongoing. But once again, it's something that we as an acute trust will welcome, because it will simply make our job more straightforward. So that's it from me. I think there are some very big things happening in the NHS as it approaches its 70th birthday in a couple of weeks' time. Daniel.
Thank you, Lawrence. So my Chief Exec's report begins with the CQC, which you all know about, but the key theme was essentially going from on the requires improvement scale from being near the bottom in near the inadequate space to, in this time, being knocking on good, so the CQC said. I highlighted in this report 3 of the challenges that they picked up. So one was our estate, particularly in A&E and critical care, which influenced their ratings. Mandatory training, which we are going to get sorted. And then we need to do more about making our staff feel more engaged with working in Epsom St Helier, and Lisa is going to talk about that on the agenda. Then lots and lots on estates. So starting with, you may remember about 3 weeks ago, there were some incredible thunderstorms, and that caused a havoc at St Helier because, as you know, we're not the most waterproof building, and quite a lot of the hospital flooded, and quite a lot of damage was caused, particularly to a lift in B block, which is going to have a repair bill of over £100,000 to put right. But on the positives, all that scaffolding you can see on B and C block, we're now more than halfway through the work. It is on time, on budget, and we've only got one more ward to go where the windows need to be replaced, which is ITU, and a big decanting of wards has happened this week to enable ITU to move out for next week so that that work can happen. We've also let some pretty big building contracts in the last couple of weeks. So the work on building a new outpatient department in the first floor of Woodcut Wing started this week, and work is now well underway to create the new surgical floor behind Mary Moore, because cardiology has moved out of its location into the old PGMC temporarily, whilst the building works to build a new diabetes centre on the first floor of Ferguson House are almost finished, that diabetes can move into that, so we can convert the old diabetes centre into cardiology, so that cardiology can move into its long-term new home. So there's a huge amount of builders wandering around the sites. Not on the estates front, but on organ donation, there's an annual report about how well trusts do in identifying patients who could have their organs donated, and we did really well. There were no patients who potentially could have had their organs donated who we didn't approach and have the conversations about, could this happen? So it's a 100% success rate. There's a new NHS acronym on its way in the summer called ERS, which stands for Electronic Referral Service. So from October, GPs will not be able to write to a hospital to say we'd like to refer you as an outpatient. They have to do it by electronically, and then we have to ensure that all our clinics are properly available online and all our clinicians know how to read and triage referrals, and it's really quite a big job. But when we get it right, it's going to be much, much better for patients because we won't have lots and lots of bits of paper lost in the system. But this is a big national programme, so we've done lots of work gearing up for that. We've been doing a lot to celebrate the achievements of our staff, and the report lists the awards given for the porters and the cleaners. We've had quite a lot of gold badge ceremonies, and there's one story that I'm really proud to share with you, which is a nurse called Bonnie, and he was so proud of his achievement. He brought his whole family to when he got his gold badge. And what Bonnie was able to do was talk to a really, really difficult patient who was being really quite unreasonable, and in such a lovely way managed to get the right outcome for the patient and for everyone else in the department. And when I met him and gave him the award, you could see what an incredible individual Bonnie is. Real credit to Epsom and St Helier. So that's all of the gold badges. The A2 theatre staff decided that they'd missed out on the Winter Heroes awards, and so decided to organise their own. So it was a great pleasure to go to A2 Theatres and present them with their own awards, and they cooked some amazing food as well. On coronary care at Epsom, one of our own staff nominated them for a gold badge, having been cared for in the coronary care, and said it was the most incredible experience. So we organised for him to come and give the gold badges to all of the CCU staff. Charlotte and Arlene organised a phenomenal Nurses' Day, another great culinary experience. That was in here a couple of months ago. And we awarded Charlotte a gold Patient First badge as part of Nurses' Day. We've launched a new thing called Epsom St Helier Hero, and this is a scheme where members of staff can nominate other members of staff for doing something really extraordinary. And we have one every week, and it comes in my weekly message, and we've got a huge number of nominations. So the winner this week is going to be dermatology at the Trust, for reducing the number of over 18-week waiters from 300 to 60 in 3 months through huge team effort. And they've been nominated by actually their manager. So there we go. We've done lots to celebrate volunteers. Again, we had Volunteers Day, and there was one volunteer who's 93 who has volunteered for 53 years, so longer than you've worked here, Charlotte, who got a very special award. Then Lawrence talked about IDEA, the new integrated care offering for Surrey. We've been doing road shows because there's a lot of staff who are transferring into IDEA on the 1st of October and we're doing road shows jointly between the hospital, the GPs and the community to show how we're all making a single team. Then a bit of good news on research, that the colorectal team have managed to put more people into a research trial than any other hospital, which is a staggering achievement for a little district hospital like us. And then gynecology have been winning lots of research prizes as well at a national conference. And then something we can be really proud about, the nursery at Sutton, which had an Ofsted inspection which we didn't feel was quite right. We asked Ofsted to come back. And they gave it a good rating and were really complimentary about the care or the childcare we're offering to the children in the Sutton nursery, so that's really good to know. And then the best bit is the new garden at St Helier. So the secret garden that opened, that the money was raised for by the neonatal team in memory of one of their staff who sadly passed away. And we have finally created a nice tranquil, calm area at the front of the hospital that patients can use. And if you haven't seen it, go and have a look and admire the giraffe. And there's a story of the giraffe as well. And I think, oh yes, how did I forget? And Jeremy Hunt came to visit. He came to Epsom and a kind of an impromptu visit to talk about patient safety. And he wrote us a really complimentary letter about everything he saw and heard. So now he has two things about Epsom St Helier in his mind. He's got steam boilers at St Helier, which we showed him when he came here, and the mannequin that he's talking to is a really special new mannequin, because not only does it talk back at you, but its eyes move and blink while it's talking. And to give you the appearance of it's a real person. And I think Jeremy was quite blown away by being able to train on almost a real person. Richard.
Yeah, Daniel, thanks very much. Could I ask you to maybe say a little bit more about the impact of the flood damage and the electrical fire, particularly in terms of how many patients were involved, over what time period, and whether we're able to quantify the sort of the clinical impact of that?
Yeah, so I can, but I think our Chief Operating Officer could do it even better. So Dan.
So I was on call, so I turned up. So the principal areas that were affected.
Normally I don't need a microphone. The principal areas that were affected were two of the wards, B6 and B5, where the water was coming in and soaking through the concrete wall. And the effect on patients was relatively small in that we were able to absorb it and simply move people further away from the walls overnight. The two greater areas of flood ingress were up on B7, for want of a better phrase, at the top of the lift shaft, where a significant amount of water had got in and caused an electrical short out to the lift switch panel, which had then caught fire, causing the fire brigade to attend at about 2:30 in the morning. That knocked out the entire lift switch panel and part of the lift itself, and it's likely that both of those will need significant repair works. I think Trevor's probably better qualified to comment on the cost. The other area of major water ingress was by the tunnel on the ground floor, which leads up towards M2 and the Children's Hospital. We're not quite sure of the cause, but water had come in off one of the flat roofs and come in through a join on the wall and the flat roof. And the tunnel was under about 6 to 9 inches of water, which we cleared over the course of the next 2 to 3 hours, and then had to put a soak away, which filled at least 2 wheelie bins to drain. So a significant amount of water came in. It also affected the fracture clinic, where there was water coming in through what we believed to be the air conditioning units, Marks and Spencer's for a brief period of time, and also a short amount in X-ray as well. Most of that is time limited, but the two main areas were the underwater tunnel, or the tunnel, and the lift shaft. Trevor, you're probably better placed to comment on the impact.
I'll just say, in terms of the sort of the clinical impact, were you able to quantify that in terms of the impact on patients?
So clinically, the impact on patients was relatively short-lived. The lift shafts could have been an issue, but we have other ways of getting up and down the building, so there's sufficient resilience. Had this been one of the wings in Epsom, I think it might have been a very different story where we wouldn't have had sufficient resilience to do so. Having said that, it's still a considerable inconvenience, both to the daily movement of staff and patients around the hospital. I think just to add on to that, the damage to the lift, because it's quite an old lift as well, is significant. We are looking at the bill being in excess of £100,000, so there will be an insurance claim on that as well. And I think the problem, because it's predominantly a new lift, we are looking at a further 20 weeks before that lift will be operational, and it's our main theatre lift. So I think in terms of accessing theatres and the flow around our patients will probably be challenged for that time. So it's not helpful for us, but like you say, we've got to have a list, but it does slow our activities down.
And then the last bit I just say at the end. So the consequence of everyone on site having to be sorting out all the water ingress meant that the flow in A&E was not as good, and we had a lot of people waiting more than 4 hours in A&E who didn't need to wait more than 4 hours if we had the resources to move people around the hospital, but people were doing the more important thing at the time. And then the last thing I should say, which isn't in the board report, is that the Merton, Sutton and Surrey Downs CCGs are meeting next week on Thursday evening, and the committees in common to talk about essentially the future of Epsom and St Helier, and the papers for that meeting should be now available online. But clearly I haven't looked because we're in this room. And if you want to know the website where they're on, I assume we know it, and Lisa can tell you at the end.
Yes, you'll find they're on the CCGs, each of the CCGs websites.
Okay, thank you.
Sorry, Daniel, may I ask, are you taking a couple of questions on your report now or at the end?
We'd like to take them at the end.
Fine, that's no problem.
Good, thank you very much. but I just wanted to enlarge on a point in the report. Very early on, you were talking about transplants and saying we have a 100% rate of approaching people who could do it. What is the actual rate of conversion of people who we ask into, or their relatives, into actually using the organs for a transplant?
Yes, I think we had 11 organs, because obviously the approach, families are sometimes agree to the donation or not, but the measure on which we have been measured in the past is that we have done all we can to facilitate a donation, but then it's down to the family. But a number of the patients who did donate, it was several organs, so it ends up being more organs than patients.
I think, Lawrence, as a more general hospital, without a neuro intensive care unit, we're relatively small in terms of the numbers of people who actually go on to be donors.
And that actually makes it a greater success, because it doesn't happen very often that there is a patient who potentially could be a donor. Then the staff being aware and doing all the things that they are meant to do is really a tremendous performance.
Thank you very much. Thank you. So let's move on now to the performance report, the integrated performance report, and I think we'll start with Ruth. Thank you.
So I'm going to take the domains 1.1 and 1.3, and then James is going to talk through 1.2. So to summarise in terms of the mortality indicators, the position in terms of our mortality rates remains a very positive position, with our HSMR being lower than would be expected for a sort of matched group of patients within the hospital setting. In terms of key points I want to highlight from 1.2, which is looking at 1.3, which is looking at wider quality measures. What I want to highlight and to pick up on is the ongoing challenge there has been during the operationally challenged winter that we've come through in undertaking comprehensive investigations in a timely way. You'll see here that in the month presented here, April, none of the comprehensive investigations were submitted within the timeframe they should have been submitted in. But I think it's important to actually notify the board that there has been a huge focus on this over the course of the last few weeks as the operational pressures to an extent have subsided. We've done a call to arms to all of our trained clinical investigators. We devoted time as part of the trust-wide quality meeting last week to actually ask clinicians to devote time to undertaking root cause analysis rather than attending presentations. And so the position now is that we have 3 SIs which are overdue, 2 of which are due to be submitted in the next 48 hours, which will get us down to only 1 outstanding. And of the remaining other SIs within medicine, there are 5 SIs, all of which now have allocated investigating officers, have had duty of candour enacted, and which are progressing, with the anticipation being they'll be submitted in a timely way. So there's been a very significant recovery exercise over the course of the last few weeks, and clearly what has been particularly helpful is that during that we've been able to look at other ways of undertaking the investigations which might allow us to complete the investigations in a more timely way. The Commissioning Support Unit are very receptive to the changes we're proposing in setting up panels. So it's, as I say, the position here in month was concerning, but I just thought it important to highlight that things have changed since then. And then I'll hand back to James to talk through 1.2.
I'll talk through some of the operational quality measures. The performance measures for stroke performance are in line with previous months. We have been constrained with capacity on the stroke unit, and we're hoping that the transition of the less acute phase of stroke illness to Epsom Health and Care will help the performance on length of stay on the stroke ward and dedicated stay in a stroke unit. But we are assured by the clinical teams that each patient is clinically assessed to be in the most appropriate environment if they need to be on the stroke unit. Performance for dementia continues to be poor in terms of electronic recording of the risk of patients having dementia, but the focus has been much more about getting a paper-based record in terms of a care plan for dementia assessment. I'm pleased to report that for the first time in probably 18 months, we have achieved the standard for VT assessment electronic recording. This is obviously only the first month that we've achieved this, but we're hoping that we're getting a little bit of traction through the better visibility of the whiteboards and the whole team working together on a daily basis to have much more visibility about patients who have not got a recorded assessment, but this will be ongoing work.
Thank you very much. Let's move on then to caring. Is that you?
Okay, so, sorry, safe staffing. Yeah. So in terms of staffing, we remain CHPPD, which is the care hours per patient day, remains at 7.9, which compares well against the national median. The issue that we're having is around the ward managers maintaining supervisory status. So the plan is that they would do that 50% of the time, but they're not able to do that because of staffing on the ward, so they're having to work clinically. And we're working towards recruiting so that we are able to get them back to where they need to be.
Sorry, Arlene, can you just explain that a little bit
Sorry.
more
So
in terms of what they... I mean, are these different people, or are they the same people who are doing this for a part of their time?
So it's the same people. So you have a ward sister who has overall oversight of the ward, and what we would like for them to be able to do is to have 50% of the time where they're not working clinically alongside their staff, to do the operational stuff to support their staff in a different way, so they're not in the numbers, as it were. But if they don't have enough staff to do the hands-on care or to deliver the drugs or whatever, they end up going into the numbers, which makes it more difficult then for them to do the other management stuff that they need to do.
Thank you. Thank you. Yeah. So next on my list is infection control.
So in terms of infection control, I remain with 0 MRSA bacteremias in April. The bit that we are struggling with is training, compliance with training. For our clinical staff, that is 79%. We have a new lead nurse for infection prevention control that started with us 2 weeks ago, and I will be working with her and the infection control doctor to come up with a different plan to tackle the training going forward, so that we can get training better, and the hand hygiene as well. We aim to improve those by working very differently.
So on that hand hygiene audit where it says 88%, what is that a percent of? What is it, 88% of what?
So the 88%, so we have 95 areas where we should have hand hygiene audits done every month. Of those, only 84 areas actually did the audit. So that's the 88%. Right. And so we need to get that percentage up, because ideally, if we have 95 areas, we should have 100% compliance with completing the audit. And then we want to then... The 93% is actually about the physical hand washing, which again we need to improve.
Okay, thank you. So moving on here, maternity. Who's going to talk about that?
Maternity, the challenge remains in the two areas of caesarean sections, which on the Epsom side is still 35.9%, which we would like to get down to 29, which is the London average. And again, on the Epsom side, in terms of use of the birth centres, which is only 7.8%. We have started some work with maternity. We had a catalyst event on Monday, which is aimed at working towards the Better Birth initiative with the midwives, but working with them so that their voices can be heard in the process, as well as develop the plan to achieve the Better Birth initiatives.
Yes. Yes.
I think, Arlene, the birth centre figure for Epsom, that was during the lift.
It was, yes.
And that was to do
well.
with the configuration of the lifts and the fact that you couldn't have women in the birth centre who might need to go
Yes,
to theatre.
absolutely.
So, because that was obviously jumps out at you.
Yes, it is.
And the caesarean rate at Epsom, presumably we're looking at why it should be so much higher than it is at St Helier. And
Yeah, no. Yeah,
Charlotte.
I'll get Charlotte to jump in. with that
So,
one.
do you remember probably about 6 months we took a paper to, excuse me, patient safety and quality, and they review every caesarean now, and Ramesh, the CD for obstetrics, and Marion are coming to next month's PSQ with another paper on the caesarean section rate. But there is no doubt with the initiatives that we're doing with more scanning, less fetal movements, there will be a national increase in the caesarean section rate. So we're not going to be an outlier.
sorry, there will be an increase.
There will be, because there will be more caesarean sections. There are more inductions going on now nationally, because it's a whole process to reduce birth injuries, which when we come to my CNS paper talks about that.
I think we have to recognise that caesareans are not necessarily a bad thing. There are circumstances in which they're right and proper for the safety of the mother and the baby. So, we need to be really careful with interpreting those figures.
I think, if I may, what's important is that we look at the caesarean section rate in conjunction with the neonatal encephalopathy rate. We don't often talk about that indicator because that indicator is looking at the number of babies who have potentially been compromised by the labour process. And what's very important for us is to maintain a very low rate in terms of neonatal encephalopathy, which we do, as well as a low perinatal morbidity and mortality rate. So I think important that we look at the parameters and the KPIs in the round.
Okay, thank you. Thank you. So moving on, patient experience, Lisa.
Thank you. On the friends and family test, you'll see a really positive view that we've now managed to, with all the work we've been doing with the teams, improve the response rate performance. Even if you look at the maternity one, which we're not hitting the trajectory yet, which is set at just over 25%, it has shown a significant increase month on month over the past quarter, and even going back to the last quarter. So that's continuing to rise, which is really positive. You'll see we've put in some word clouds at the bottom of the report around the negative and positive comments. We get thousands upon thousands of people writing with positive comments on the FFT information. All of these are fed back to the wards, so all areas and all wards have access to their specific data, and that's proving really positive in terms of us being able to address negative issues, but also celebrate the good ones, because I'm always quoting at the induction, over 93% of our patients have something really positive to say about their experience at Epsom and St Helier hospitals. So we celebrate those as well as do something about the challenge where we've got challenges. Going on to PALs and complaints, again we're seeing a continuation of the use of the PALS service, which is fantastic, and staff are reporting back that they're using this service as well, so that's really, really positive. and part of that's because we've invested in the staff and now have regularly and sustainable 2 services running, one on each site, which are manned by people as opposed to a phone system, and that is unusual when compared to some of our surrounding trusts who just run a telephone service. We're very keen to have a personal service and offer a personal service, and it enables us to work with specific wards where we're picking up themes. So you'll see there some work we're doing with ED, St Helier, AMU and B3, so we're able to really quickly pick up where we're seeing themes. Complaints continues to be a really good story in terms of, one, dealing with the backlog, which is really critically important to ensure that we don't have a backlog, and we are reporting the lowest backlog we have ever had in the history of making this recording, so that's really positive. And we're also seeing an improvement, continual improvement in the turnaround to time scale for our complaints, and those two things together highlight that although that we're returning complaints quite quickly, it doesn't mean that we're doing them at reduced quality. It means that we're maintaining and improving the quality whilst reducing the backlog, because if a complaint comes in and they're not happy with the response, it comes back and it produces some of our backlog. So that's a really positive situation to be in, and what's really important, it's really working with the teams. So you'll see at the bottom of the report where medicine achieved an 82% of their target, which is extremely strong performance, considering they have 4 times more contacts in this form than any other division. So they've really taken this on board and taken it seriously, and are working very, very hard to improve performance, which is great to see.
Good. Thank you very much, Lisa. That's very interesting. Yes, Pat?
Can I just say, I do think that we ought to, as a board, congratulate the PALS team for an 100% performance on timeliness in response to an increasing number of contacts, and to the complaints team for having got on top of a backlog that has been around and worried the non-execs certainly for certainly ever since I've been on the board.
Yes, no, I think that's really good. I mean, complaints was definitely an objective for the last year, and it's really good to see that has been changed and transformed. I'm still quite interested that we get, you say in your narrative that there are sort of 3 areas where, if you like, complaints tend to focus: the ED at St Helier, SAU at St Helier, and Swift in Epsom. Is it? Can you detect any reasons why they should be those specific places?
If to be fair to ED at St Helier, it will be the vast volumes that actually go through. I think some of the others, from talking to the teams, have been driven by the pressures that we've been facing in terms of waiting. So a lot of the complaints we deal with are people raising concerns about the fact that they believe and have felt that they've had to wait longer than they have for one part or all parts of their journey with us. So I think that's why you're seeing it reflected in those areas, Chairman.
Thank you very much. So moving on, next is cancer. Dan?
So some good news. We've been forecasting for a while that the rapid prostate pathway would come into effect. We would expect to see the benefits of that in March. And I'd actually like to say that's exactly what has happened. We've delivered a 62-day performance of over 90%, and even allowing for the reallocation under the incoming new 38-day rules, we've performed at just over 87%. So a really strong performance from the team. The thing I would flag up is the significant rise in 2-week wait referrals compared to this time last year, bearing in mind that we report March in arrears. My one concern with the increase in referrals is we're not seeing a huge rise in found cancers, but we're consuming a large amount of diagnostic tests. And you can see on the next page how close to the wind we've sailed on achieving the diagnostic standard in part as a consequence of that. So some really good news, exactly at the point we expected to see it, for exactly the reasons we expected to see it as well. I won't pause any further on cancer unless there are any questions.
No, I mean, there was quite a lot of publicity, wasn't there, about us and prostate cancer in the news and on national radio and TV, and has that had an impact on flow and
Yes.
And volume?
Yes. Yeah, there's some anecdotal reporting from the teams and a very small amount from postcode data that we're seeing more people opting to be referred here as a consequence of our rapid diagnostic pathway for prostate. So I think that's absolutely the case. What we'll have to see is whether that levels out in time. There is also some suspicion from the consultants. There's a bit of the well-known Stephen Fry has been diagnosed, so that's was in the news at the point where many of these referrals would have been made. So I think we need to see how that pans out over the next month or two.
Thank you. Do you want to go on to elective care?
So if I move on to elective care, this reports the month of April, which was the first full month of our RTT stabilisation, and we have reduced the backlog by some 200 patients, improving our performance in percentage terms very slightly, and the evidence for May is that that trend is continuing, with some 350 to 400 patients coming off in the month of May. So there is absolutely no doubt that the things we're putting in place are now having an impact on our RTT performance. As I go through, I've mentioned the diagnostic standard, which we have achieved, but I think that has become very close in consequence of the need to turn around faster, more 2-week wait referrals. And I'm just asking for some digging to be done into what impact that will have over the next couple of months to see whether that's a sustained rise or whether that's a temporary blip. In terms of elective stay, in terms of overall, that hasn't really changed, but there's been a jump in the 65-year plus length of stay, which at the moment I'm not clear about the cause of, and I think we just need to see whether that is going to change permanently or whether that's in part of the fact that we've done some more of the routine surgery now on more difficult patients who've had complex social needs, and I don't know whether there's a end of winter factor and we've done different types of elective surgery or whether there's a fundamental change going on. And again, I think I just need to monitor that over the next couple of months. But we've been churning through elective activity throughout April and May, so that's going well. And last minute cancelled operations, whilst there has been a small rise in a non-achievement against the standard, I think it's worth considering how many people we're bringing in for day cases and how much that stresses our day case trolley basis. And on many occasions we've been able to do it by using ward beds, by flexing day case capacity, and patients have reported that whilst that's not great in experience terms, they are grateful for the opportunity that we're not cancelling them several days in advance. So we're getting more work done as a consequence of sailing slightly closer to the wind on that front.
Yes, I mean, the phrase "sailing slightly closer to the wind" is always worrying. But I see your I see your point. Do we ever get to the situation where we have to use day case facilities and beds for people who are staying overnight or longer?
No, we absolutely try not to do that in surgery. No, we have recently directed that where there aren't private patients sitting on Northey, we will always allocate those to surgical activity. And we're trying to look at how we might be able to create more day case capacity on the Epsom site, and that work's ongoing at the moment. But we absolutely don't use trolleys overnight for that purpose.
So the last bit that Dan said is really important. So we're creating an estates plan to expand the amount of day surgery capacity at Epsom from hopefully October-ish, about Christmas at any rate, so that we can actually sustainably deliver more surgery on the Epsom site.
Good, thanks. So, emergency care pathways then.
So, in common with many others, April remained a really challenging position, but we have retained our position as third in London for both Type 1 A&E attendances and all type attendances. So you can see the upwards trajectory in performance, and we've continued that through into May, and the signs for June are good at the moment as well. What I would draw your attention to is the new metric, which we will expand further next month, on stranded patients. I think this was picked up in the feedback from 15 Steps, but NHSI have introduced a new measure of stranded patients, which is all those inpatients who remain in a hospital bed for 7 days, and super stranded, which is 21 days and above. You can see that the metric for stranded is very slightly higher than it was this time last year. And in part, I think that's because March and April were difficult in terms of acuity of patients presenting. But also, if you look at the delayed transfers of care, you can see there's a significant rise year on year compared to this time last year, and that will be contributing to that factor. And our patient flow programme is aiming to address that using stranded patients as a specific metric.
Yeah, you're going to have to explain that to me a bit more. I can't quite understand what it means. So these percentages are, it says here, the percentage of stranded patients per day on average. So that's 49 and 53% of what, precisely?
Can we leave it till next month? Because we haven't got this data shown right, and we're going to redo it to say that because it's quite complicated, and we can show it more easily, and then we can have the conversation, I think. Otherwise, we're going to get quite...
Well, I'm glad you've said that, because I was worried that I just couldn't understand it. So we'll bring that back next time and talk more about it. Thank you.
And then in terms of ambulance handovers and ambulance arrivals, the numbers of ambulances has dropped very slightly, but they continue to present in larger numbers later in the night, later in the evening and overnight when our staffing is thinner. And so whilst we've been successful in reducing some of the delays in St Helier, Epsom continues to be a concern, but we are absolutely not on CCAM's radar as one of their major offenders. But I think it's a concern to us in terms of how quickly we can release the ambulances to go back out onto the road. And we're just trying to work with CCAM at the moment to see whether there are any very quick wins that we can make, one of which is simply displaying the ambulance arrivals board in Epsom ED. It's probably worth noting, though, that the CCAM ambulance arrival times out after 30 minutes, and we don't have enough to keep it updating permanently, so it switches itself off. So we're talking relatively low numbers overall as part of CCAM's activity.
Thank you. Ian.
I'd just ask a question, Dan. The delayed transfers of care looks like something that's on the rise. So what traction does the Trust have to try and resolve that? Because clearly that's going to impact on flow through the hospital.
So I think that's absolutely fair as an observation. There are several reasons, one of which is that Sutton, and it is primarily London Borough of Sutton, reached the limits of their ability to meet social care needs after a very difficult winter, and they're just working out how they can bring more capacity on stream to support that, and they are absolutely committed to helping us. The second vehicle is, as Daniel's already mentioned, Sutton Health and Care, which is designed to improve the performance across the boundaries between hospital, community and social care, and I think that will go a long way to improving it as well. But the key thing about detox is that they fall within the super stranded measure, so you can actually, you've got a thing that says what might be the hospital's concern, what might be the local authority, what might be community care, and what is it where it's a mixture of all three, so it brings it into sharper relief.
Thank you. So I think it's also worth saying that Sutton changed all its providers of home care in the month of April, and they now have a lot more capacity than when they started, but there was a slight delay in the transition between care providers, so it has come right down, and they did tell us that that was going to happen in advance.
Thank you. Chris, do you want to comment on that from a perspective of a Sutton GP and also, you know, in this whole, community-facing role?
So, I mean, I think the key thing is, I mean, it is always interesting when who you sit with when you talk about delayed transfers of care, because if you sit with another audience, perhaps based around the borough, they will find different reasons for delayed transfers of care. But just to pick up the point, I think the answer to this must come through I'm not quite sure how to say the acronym of EIA, but Sutton Health and Care, IDEA, sorry, I missed the D out. That's the solution has to come out of that, and I think that's what we need to hold the Trust and its partners in those two schemes to account for, because it really doesn't do good, particularly older, frailer people, any good to be staying in hospital for any longer than they absolutely need to.
Thank you. Thank you very much. So is that you done? Thank you, Dan. So moving on to well-led and workforce. Kevin?
Okay. The first page is a page of two halves, really. The vacancy position is complicated by transfers in and transfers going the other way as well. So we've transferred in transport services, so it's increased the number of staff who fall in the clinical support category, but we've also transferred in a lot of vacancies, so it's put the vacancy rate up. we've transferred out estate staff, which has meant that that vacancy, which is a green line, has come down because we were using a lot of bank staff in that area, and now they've got permanent contracts, and that's very positive for them. So that's why it all looks a bit confusing if you try to drill down into the detail. But overall, I think one of the key things that we keep focusing on is our clinical workforce. And whilst you've got that upward line, which is about the transport staff, because they're categorised clinical support, the key thing in that narrative is that it's down by 2. So in a sense, it's stable. What we're concerned about, which is on the next page, is both the nursing and medical. And we're doing quite well to recruit into the medical, and the People in OD committee looked at the trajectory on medical, and as you said, Lawrence, earlier in the day, we have 10 doctors that we would have been looking to manage through to get those visas, who now should just run through that without any problem, so that's positive. And we expect the medical vacancies to come down significantly in the August rotation because we're seeing good fill of the training posts. That affects the bottom half of the page, which is about agency cap and spend. Predominantly, this is about doctors going over the cap, so when we get to August that will improve, and we're working with London Trust about a London cap that we'll be going live with in a phased way in July, August and September. Because we've got different pressures, so we're doing it in a phased way. And also medicine are the big spenders on medical agency and over cap, and we've got a plan from them, a quite robust plan about how that will come down in August. So we are over the trajectory at the moment, but we're hoping that that will come down due to the doctors. We have got some pressures on the nursing side, but again, Arlene is picking that up from Charlotte about both the specials project and the controls, and also we've had more areas sort of closed over the last few weeks, so that should help for June. The second
could I just ask a bit more about the change with the visas, because you said earlier on about the bureaucracy being removed, but actually the process will still be there. The visas will still need to be got. It's the quota which is being removed. So presumably again there will be a backlog, and I wonder if we're looking at how we can get to the front of that queue rather than the back.
So the way it's been working is, and there's a little graphic on the news last night which is quite useful for you to be able to see it, is that the starting point is certificates of sponsorship, and we've got a number of doctors in the pipeline where we've got the certificates of sponsorship, and they've been continually being put forward to get the visas, although we've managed it a lot. In the last few months we've managed a way around getting some of them through emergency care, but in essence we've got some that are almost at a gate that when they open that gate they should come through, and we can then start the process because they would have got that approval. There's others that are a bit earlier in the pipeline, so that we will be going through the processes as we were before, because they've got other things to do before they get to that sort of gate, if you like, at the visa. But we expect, whereas in previous months they'd got to the gate and been stopped because they didn't have enough points, there won't be a gate there anymore, and they just walk. I shouldn't be really using analogies if it's an airport, but there's a gate there that means they're just walking through is how we expect it to work. Chris.
Thank you. Can I just ask about recruitment to junior doctor training posts?
Yep. So we're looking pretty good at the moment. I think we've got 9 gaps in the posts that we've got, but we've also got quite well developed backup plans for bringing people through in terms of clinical fellows or MTIs, which is the overseas route, or trust grade posts. So I think that our main concern about junior doctors at the moment is particularly in paediatrics. They don't rotate until September, but again we're given indications that it will be better for us in September, but we haven't got the names yet because they're not quite close enough in terms of the rotation. But it's not looking too bad in terms of the deanery what we call the deanery, don't we, in the old school, but it's Health Education South London.
Thank you.
Then just quickly moving on, we've seen sickness coming down compared to last year. That continues. That's a really positive April position, and the May position is better compared to the previous May, but it's slightly up from that 3.5. We've got a big focus at the moment on appraisals, which we discussed at the People in OD Committee. We've got to the phase where we're been giving out improvement notices, but what we're picking up is that we've been insisting that it has to be recorded on our electronic system for it to count. The feedback I'm getting from the HR managers and the managers that are now having those conversations with managers, line managers, is that they've done paper copies, but they haven't been loading or using the electronic system. So we're going through that process of capturing people who have not been using the system. But that position at the moment is we've got 73% that are complete. We've got quite a lot of areas that are 100%, and we're aiming to reach the 90% target and above by the end of June. Statutory mandatory training, as you heard earlier about CQC, mentioned that. We're going through a very thorough review of how we provide access to training, how we capture the training, and that's a conversation for tech next Wednesday, so that we'll be focusing on getting that performance back up for the end of September. And we've moved it out of the winter period in terms of that performance management because of the pressure on staff to the winter pressures.
Thank you very much, Kevin. Back to Lisa for comms and engagement.
Thank you, Chairman. Just to say, vacancies and jobs continue to be the top search for anybody using our website, which is really positive in supporting the recruitment drive. Our Twitter followers continue to increase, and particularly we've highlighted the Easter egg donation, as that got a lot of coverage and following locally and nationally. And positive media coverage for the month, I think, really to highlight the maternity services on two fronts. One for their new advice line, which gained a lot of coverage and has been really, really positively received by patients and people using the service. So that was fantastic. And also our wonderful midwives who completed the Isle of Wight challenge, and that was an amazing achievement, and they were raising money in the process. So they did a lot for us in terms of gaining some really great coverage during the month.
Good, thank you very much. Then finally, Rakesh, Finance.
Thank you, Chairman. 3.3. Before I go into the performance for April, just want to remind the board and the public that last financial year all trusts were allocated an additional cash if we achieved the financial plan and A&E, and that was called the Sustainability and Transformation Fund, STF. For this financial year, 18-19, that STF has now been rebranded Provider Sustainability Fund. But more importantly, the criteria for accessing that additional fund remains the same as last year, i.e. we have to hit our financial plan and we have to deliver our A&E performance target. So the first indicator you see on 3.3 is our financial performance excluding that Provider Sustainability Fund. And in the month of April, so our agreed control total is £28.2 million deficit. We agreed that with our regulators during the planning phase. And in the month of April, we were £300,000 behind plan. So we were adrift of our plan for April. There were two underlying reasons for that. Firstly, the board will recall that we are now on a payment by result contract for significant elements of our activity, and we're behind on large swathes of our income in April. Primarily maternity, so births have been down in April as they were in the latter part of last year. And when we when we look at all the other providers in the sector, they're equally as down, and actually Croydon and Kingston's reductions are greater than ours, so there is a trend happening there. and we were down in April for some of our elective and particularly outpatient activity. The other reason we're behind plan is we've heard how busy ED has been in April. So our ED expenditure was over budget, and we had to open up significant escalation capacity in April that resulted in larger than planned spend. So in April, we were behind plan. However, at this early stage of the financial year, we're still forecasting to hit the financial plan and hit our performance target, and that's the next indicator. So so we're still 300k behind, and we're forecasting to receive our provider sustainability fund. In order to achieve our financial plan, we've agreed with our regulators, and internally we're planning to deliver a £17 million cost improvement and efficiency plan. And in the first month, against a target of just under £1 million, we were slightly ahead of that plan. Obviously, you can see from the graph that the trajectory gets increasingly more difficult in the latter part of the year, and a lot of focus from the management team and the finance team and actually the execs is to see how we can ensure that we deliver the higher trajectory in the latter part of the year. We've talked previously about the capital program for this financial year, significant at 50 million pounds. You see the red line in the graph, how the trajectory increases as the year wears on. And Trevor is predominantly estate stuff, which Trevor monitors, but we have a significant IT investment as well this year. And in April, we were on target. Cash is a key metric for us, and in April we were holding more cash than we planned, but we know why that was. It was some of the capital schemes were deferred, but we had the cash up front. But the target is to hold £2 million by year end, which is what our regulators expect us to do. And lastly, as I've mentioned at board before, our Better Payment Practice Code is an important indicator of cash management, and we maintain a high level on that as well.
Thank you very much, Rakesh. Can I just ask, obviously we've been talking about the IDEA team and then Sutton Health and Care and the community contract. Can you give an indication of how much, let's say by this time next year, how much our overall turnover will change?
So IDEA the full year income and expenditure for IDEA is £20 million, and for Sutton Health and Care it's around £5.5 million.
Next year
it goes up, yeah.
about 15 or 16.
Yeah.
So it's quite a significant.
Yeah. It'll change the dynamics, yes, significantly.
Financially, yes, that's interesting. Thank you. Thank you very much for the integrated performance report. We're a bit behind schedule, so on the board committee reports, I'm not going to table them. They're all available unless there are specific points. Risk. It's never on my list. No one ever puts on my list. Risk. Peter.
Thank you, Lawrence. I'll just be brief.
Yeah.
So the broad risk register reflects the significant risks across the 4 domains of staffing, variability of care, our estates and infrastructure, and our finances and long-term sustainability. At the last park, we picked up 3 new risks, or adjusted materially risks. One was to, in the element we were just talking about, so one of our challenges is our ability to deliver everything that we are having to do. So we've reflected that the capacity and capability to manage that all also includes the significant effort required to deliver working in partnership, that we think is definitely the right thing to be doing, but that it comes at a challenge and a pressure. So that was one element. In the variability of care risk, we have added a concern that has been sort of bubbling away in the background around anaesthetic cover to the labour ward, which largely due to middle grade and junior staff, and that is currently being mitigated through consultants providing additional cover and ensuring that the service is safe, but that's becoming increasingly challenging. So that's the one around obstetric cover. And the third one is is around infrastructure, in the sense that to ensure that the endoscopy unit continues to have the external national accreditation. There's been an additional requirement to ensure that the data is fed into a national database. If we don't make the changes to our systems to enable that, then we would potentially risk losing our JAG accreditation, which could mean then that patients won't come here, and then that's clearly not great for patients, and there are other consequences too. So those are the three material changes and additions to the risk register that were agreed at the last Performance Assurance and Risk Committee.
Thank you. Any further questions? Right, in that case, we're going to move on.
Sorry, Lawrence, may I think I would just like to say that the initiatives we've started on a people perspective.
No, I was going to say that if any chairs of any of the committees would like to say anything, please say so. Aruna.
Sorry. So on the people front, I know Kevin talked a lot about the KPIs and the statistics that we have right now, but I think it's fair to say from all the conversations that people have been hearing, we do have significant staffing issues that we are working on. We also have significant issues in terms of our turnover and the culture and morale in our people, in our staff and people working for us, and also gaps in the equality and diversity front. And I would just like to share that we have started making very positive steps towards addressing those concerns. To begin with, we had a very good event, kickoff event that Arlene chaired and spearheaded, really related to shaping our future and targeted at midwives. And I think Lisa started to do quite a lot of work around hearing the voices of the people around the wards and floors. So there's going to be quite a lot of work in terms of putting our people first and addressing the concerns of our people going forward. So I just wanted to share that, and also that we have launched the EDI. We have a chair and vice chair for the EDI committee, and Martin's actually going to chair from Equality, Diversity and Inclusion. Sorry, I'm using too many acronyms here. And Martin's going to be chairing the Equality, Diversity and Inclusion committee going forward. So I thought it was important to share those initiatives and the strides that we're making. Thank you.
And I just wanted, in the week of the 1 year on from Grenfell, to say that at the last PSQ meeting we got a report, the final report, independent report from the fire safety side of things, to say that our cladding is safe. An independent review has been done over the past year.
Thank you. So we'll move on to the CQC inspection and regulator breaches update. So hand on to Ruth.
Thank you. Just to put this paper into context, you'll be aware that the CQC published their report into our trust on the 14th of May. As a consequence of that, we were required to respond to the CQC by the 7th of June in relation to 3 areas where they found we had breached, if you like, their regulatory standards. I think it's important to note that this is the first of several papers that we'll be bringing to the board in relation to the recent CQC inspection. We are currently in the process of formulating a comprehensive action plan to address all the issues identified during the inspection. But clearly the priority here was to ensure that we had timely and swift progress against those regulatory breaches. The regulatory breaches are appended to the summary document here, and if I try and translate and decode what they were, there was one breach in relation to good governance, and in summary, we believe that related to the structure of our board assurance framework, our kind of clinical governance in terms of how we report and learn from incidents, and also issues in relation to how we keep our medical notes and how we keep our medical records. In terms of staffing, there were concerns around our statutory and mandatory training rates, which has been set historically at 95%, the numbers of staff we employed and the pressures our staff are facing, and also concerns that a particular staff group perceived that they had been treated unfairly. The final area for which we received a regulatory breach was in relation to our compliance with the Mental Capacity Act. And when the CQC issue these breaches, what they don't do is specify exactly what during their investigation led them to find you were breaching the guidance. So we've clearly gone through the report, every single page of the report many times over, and we believe that the concerns around the Mental Capacity Act relate to how we record capacity assessments as part of our DNA CPR process, and also our application and documentation of how we use a restraint policy. So those are the key facets that we believe have driven the regulatory breaches. What you've got here is the return that we submitted to the CQC on the 4th of June, which summarises all of the immediate steps that we have taken and will be taking in order to address those. And they clearly will be formulated into an overarching trust-wide action plan in relation to the corporate regulatory breaches. And by the time the board next meets in July, will also be supplemented by an action plan that relates to the wider findings of the CQC inspection. So that's a summary of the document that's attached here.
Ruth, since we have to work out what it is that gave them the reason to impose the regulatory breach procedure, do we at any stage get an acknowledgement from the CQC that we have correctly identified that which we need to do and have done it?
Not formally. We are still awaiting acknowledgement that this document has been received. I have no doubt they'll be going through it, and one would hope that if there are issues in the inspection report which we're not addressing, that there'll be prompt and rapid feedback. We actually have a quarterly meeting with the CQC regional team, and we have a meeting scheduled for next Friday, where I hope that we'll get face-to-face feedback and confirmation that our actions are in line with their expectations.
Thank you. Any further points on that one? In which case we'll move on to a serious incident report, Ruth, never event.
So this is to ensure that the board is cited on a never event which occurred in December 2017. You will remember that there are 15 categories that are described as never events. They are nationally mandated, and the definitions are stipulated as a serious, largely preventable patient safety incident that should never occur if available preventable measures have been implemented by healthcare providers. The incident here, and I apologise for the typo in paragraph 4 because it was December 2017, relates to a retained object after abdominal surgery. The patient had a slower than anticipated recovery period, and so post-operatively, after a period of several weeks, was found to have retained swabs, which was undoubtedly contributing to their delayed recovery. The patient underwent subsequent surgery and has recovered well. We've enacted very fully a duty of candour with the patient and their family, and have completed a panel-based investigation into the case that's come up with a number of recommendations which have been implemented across the organisation and which have been reviewed at the Patient Safety and Quality Committee. So you'd appreciate that we are constrained by the amount of information that we're able to share in relation to a specific patient in a public board, but it's very important that the board is cited on this incident and the actions that have been taken within the trust.
Thank you. It's not the first time you've had a retained swab, is it? And I mean, what we need as a board is assurance that the processes have been changed and developed so that the risk of this happening again is as minimised as possible.
Absolutely, and that was the immediate action that was taken. So although the investigation took several weeks to complete, there was immediate streamlining of the process in place on both our sites for counting and accounting for swabs during surgical procedures, and that is being followed up with audits which are observational rather than paper-based, because clearly changing the policy can readily be undertaken. The important thing is making sure that compliance with that policy is maintained.
Okay, thank you. Any other points on that one? in which case we'll move on to the mortality report.
So this is the second report that we brought to the board since the Learning from Deaths recommendations came into play around a year ago, detailing how the Trust is approaching mortality reviews and mortality reporting. This is presented in arrears because the mortality reviews do take some time to undertake, and it summarises the position for Q3 of 2017-2018. We've previously described the mortality review process that we use, which in essence is a two-stage process whereby all cases in scope should have a succinct mortality review undertaken, and cases that meet a defined threshold, which is nationally mandated, must undergo a structured judgment review, which is a more detailed review by a trained reviewer. I think the context to note here is, as a trust, we have about 120 deaths per month, and a structured judgment review can take up to 2 hours per case to actually undertake. So clearly we've had to train a number of reviewers to undertake these reviews. We now have 6 trained reviewers who meet as a panel and review cases. The imperative and the importance being to ensure that when people do die in our care, we review the quality of care they've received and whether there's any learning that could be more widely applied across the organisation. The report, I hope, is reasonably self-explanatory, but I just wanted to highlight a few points, if I may. Table 1 shows you the new dashboard that we've developed, so that in a page you get a view of how the Trust is approaching mortality and how the data is being presented and shared. I think to highlight the key points in this that you will see, we undertook stage 1 mortality reviews in 20% of potentially eligible cases, but actually had a higher completion rate of the more detailed structured judgment reviews at 53%. The important thing, as I say, is to ensure that in reviewing the case notes, we come up with learning that helps our patient care. I think what has been really important to take from this review so far is that in the majority of cases, we actually offer good care. And so you'll see here at the top of page 4, there's a table with some numbers on it. This is the methodology that's used when undertaking a structured judgment review. The care is scored, with 5 being, if you like, the maximum mark. And you'll see here that it's scored in relation to the first 24 hours, ongoing care, end-of-life care, and how the notes are completed. The aggregate score for the patients undergoing a structured judgment review is 3.4, which reflects a level of care that's somewhere between adequate and good. And in the majority of cases, there was some positive learning to take. We saw actually good compliance with the DNA CPR policy. We saw very timely escalation and referral to intensive care services, which is a very important point to note, and that dovetails with what we're seeing through our SI reporting too, that we are responding in a more timely way to our sickest patients. However, in terms of areas for further development, one of the themes that's come through is around the timing of giving medication, making sure we give medications in a timely way, because for some patients, giving the medication at a defined point in time is absolutely time critical. How we manage the fluid balance of our patients is another area that has not come through SI investigations, but is coming through here, and we're starting to do some work on that. Ensuring that we have documented escalation plans, and again, making sure that the care that we are able to offer and give patients in our escalation areas is equitable to that given in our main ward areas. So those are the themes that are emerging so far from review of deaths during the winter period. Clearly, those lessons get acted upon and discussed through the Trust Radar Committee, and we will be continuing to share the findings from mortality reviews with the board on a regular basis. Thank you.
Thank you.
Can I just be clear? At the very end, it says Appendix 1. It says criteria of patient death for a level 1 mortality review. is that level 1 or level 2? It should be level 2.
It should be level 2. Those
That's
are
what I
cases
thought.
that need the more in-depth
Yeah.
review.
Okay, so that's all right. Okay, good. So, I mean, the important thing to this, to me, is that we actually dynamically learn from it, and we don't just sort of fill the forms in, and we actually positively use this as a helpful thing to help us improve.
Absolutely, and talking to the national team, because all trusts are obviously doing going through the same process. The focus very much, as they quite rightly say, needs to be on the quality of the learning and review, and the advice very much is to focus on that as opposed to ensuring that we get 100% coverage of all the cases. So we are trying to balance the two, and already have been able to make changes in response to the feedback here.
Right, we'll move on. And Charlotte, Clinical Negligence Incentive Scheme.
Thank you, Chair. So this paper outlines how we're improving maternity care and safety for our population in the Trust, whilst applying for the Clinical Negligence Incentive Scheme from what was called CNST, but is now called NHS Resolution. And if we're successful, the Trust will be refunded its insurance premium, basically, in August. And so we've had to set out how we are achieving this. And the backdrop to this is in 2016, Jeremy Hunt launched a real ambition to halve the rates of stillbirth, neonatal deaths and brain injuries. And we talked about the national encephalopathy rate earlier, and that in the IPR, and that relates to this. They want us to achieve this by 2030. So they've incentivised all trusts to sign up to this, whereby we implement 10 key safety actions, and those are detailed in the paper appended to the front page. Our job is to demonstrate through all the evidence that we have achieved this, and also to submit a board declaration by the 29th of June. So we've gone about it with the Women's and Children's Directorate, with the Director of Midwifery and the General Manager and the Clinical Director, and the evidence has been assessed by them, and we took it through PSQ, and I also sat down with Pat last week, and we spent some considerable time going through all the evidence to assure her. From a governance perspective, we've been through PSQ, the Chief Executive's team meeting. I've taken it to both CCGs who are happy, and it's also been through the SIP programme board as well. So this is for the board to finally note that we have the evidence to demonstrate that we can achieve the 10 actions, and for us to submit it nationally.
Thank you very much.
I just wanted to confirm that I did indeed go through the whole file of evidence, which has not been asked for centrally, but no doubt they may come and look at a sample of trusts who have said that they have achieved this standard, and I didn't want us to be signing off something the evidence wasn't there. Apart from a couple of things which have subsequently I've been assured, I've seen evidence that we have also complied with those. All the points are met by the evidence in the file. So I think Daniel can sign it with a fair degree of confidence.
Good. We'll tell him that when he comes back. And can you just, how much is our CNST premium?
So Rakesh, you
Do
can
you know that, Rakesh?
We should get about 740,000 back.
It's nearly
£7
7 million.
million?
Yes, it's a significant part of our expenditure. Getting over the last 2 years. This year we went up by 24%. Last year we went up by a similar amount as well. And the biggest drivers are maternity.
So if we're assessed as positive, we would receive 740,000 back. But I must stress this is the right thing to do for women and their children, first and foremost.
Yes. I mean, the whole CNST system is one which is, I know, is quite controversial, because basically your premiums relate to negligence cases that have been settled, and as we all know, some of those negligence cases could be 5, even 10 years old. So, well, even 20 years old. So you pay a premium now based on things that happened a long, long time ago. And I know that nationally they're looking at this to see whether that's the right way of doing it. But at the moment, that's the system, isn't it? Good. Well, thank you very much, Charlotte. And thank you for everything else, of course. So we're now going to move on to a summary report from the Audit Committee. Elizabeth.
Yes, thank you, Chairman. Well, as you would expect, April and May are busy times for the Audit Committee work. And you can see here the detailed work which was done at 2 meetings. First of all, to give people assurance that we completed all of our regulatory submissions on time, and all of that work has happened. I just want to highlight 2 or 3 things that the Audit Committee's been doing. We heard earlier about the fire in the lift shaft, and you may recollect that something that Audit Committee has been taking the initiative on is having a reporting process for non-clinical serious incidents. And the first incident which is going through that is the lift shaft incident that we heard about earlier. And that means that we can get more confidence, well, we can have confidence that lessons are learnt from it and are fed back for the benefit of the Trust going forward. Another area that that Audit Committee is picking up considerably is around the area of cybersecurity that Peter is leading on. This is so important. This is not going to be a matter which is going to go away, and we have to make sure that we can move forward at the appropriate speed and that we've got proper governance security around it. You will also see on the reports of the Audit Committee that we have taken on new internal auditors. We now have BDO as our internal auditors, and we are looking forward to working in partnership with them. Moving on to the year-end work, I wanted to remind people that the work of our external auditors doesn't just cover the financial data that we have to submit, but it also does cover our quality account. And in particular this year, they looked at our data gathering processes and procedures around 2 very important metrics, our CDIF reporting and also the VTE reporting that we have talked about so much at board level. As part of the external audit work, the external auditors KPMG have made some minor recommendations to us. They have also followed up on the recommendation which was made last year concerning keeping our asset register up to date, and I'm very pleased to say that Rakesh and his finance team have put an enormous amount of work into that this year, and we now have an excellent document. Finally, there is a piece of work which is done by KPMG when they take the risk registers of all of their clients and compare them. And they put us into this document. I think it's a publicly available document. And you won't be at all surprised to hear that we are outliers in that analysis. And the reason we are outliers is that other NHS trusts do not have as many risks on their risk registers which relate to the quality of their estate as we do. We are a very different looking trust if you look at our risk register from other trusts. So thank you very much, Lawrence.
Thank you, Elizabeth. That's very interesting. And I think it's clearly relates to many of the issues we have been discussing. And that gives us a lot of confidence that the Audit Committee is actually looking at important issues and the right things in the right way. So thank you. So we're moving on now to Dan, RM Partners. That's is Royal Marsden, is it? Royal Marsden Partners, yes.
Yes, this is a report we've been sent by the Royal Marsden for our board to note in terms of some of the work they've been doing across the year. I would absolutely echo some of the work they've done in terms of developing our new pathways, working on lower GI, the diagnostics in particular. I think the key question they've posed at the end is how would they like us to report? And I can make a couple of recommendations if you would like. I would suggest that we would like something quarterly, and I think what we probably want is an update on how our performance has been affected by the 38-day transfer protocol and where they see some of the issues are that would allow us to achieve success. And that, for me, I think would expose some of the issues that we're working on operationally and identify where they might sit at board level.
Thank you. Dan, I think it would be useful for everyone if you just explain in a nutshell what RM Partners actually is and what it does.
Yeah. So Royal Marsden Partners is a West London-wide partnership of all of those hospitals who work both as primary cancer treatment and diagnostic centres and as specialist centres, particularly the Royal Marsden, which is clearly an established national lead. And the aim is to work on developing better pathways and processes for moving patients through the various stages of their cancer diagnostic assessment and then onward treatment, and then work out the effectiveness of those in terms of long-term survival rates. Because it's got such a fantastic reputation, it also attracts research and development funding, and in part it's been thanks to our membership of the Marsden that we've been able to do so much work on our prostate pathway. So it's a really useful vehicle, and it meets regularly both at a chief exec at my level and then again at a working level each month, so they can review and work through issues, escalating them as necessary. And it's been the Marsden partnership that's very much been in the driving seat of working out how it is that we and all of the district general hospitals can improve our performance against diagnostics for 38 days to allow everybody a good chance of being treated within 62 days, where treatments to onwards centres such as the Marsden or George's are required. So it's a forum for bringing people together and then channeling research and development funding.
And just the new geography of West London for this, so that's every hospital from Northwick Park and Hillingdon down to Croydon is in it. So and that's because the Marsden have a Fulham Road base and a Sutton base. So it includes Imperial and St George's as the other parts of the cancer centres that go with Marsden as well. And it's essentially one of the government vanguards. So it has had many millions of pounds of funding for the last few years, and now under the Transforming Cancer Services banner, there's many millions for this year as well. To invest in improving cancer patients, cancer care, and they've got a big focus to work with GPs this year on how to detect people who may have cancer earlier in their pathway, which is why I think we'll see a continued rise and increase in referrals of 2-week waits.
Okay, thank you very much. We'll move on now to contracts over 50,000. There's the normal list. I've got a question on this, which is the one about the ambulance rental, Trevor. We're renting 50 ambulances because we have transferred all the staff who were outsourced, we've transferred them all in-house, which is good, and we now obviously need to give them ambulances to drive. So is this a permanent solution or a temporary solution, or what are we going to do in the longer term?
It's very much a temporary solution, Lawrence. As you know, we had about 6 weeks to move the service from an outsourced provider to in-house solution, and there wasn't a ready fleet of new vehicles that we could purchase, so we went to a provider that could give us 56 ambulances that are of varying ages to enable us to provide the service. We've agreed that contract for 6 months. And I think at the end of June, we're looking at reviewing the service provision and what is the best option for the Trust to proceed in terms of proceeding with its procurement, in terms of outsourcing the service, or looking at is it best to provide the service in-house longer term. And it's something that will come back to the Trust Board about making a decision on.
Thank you. Thank you. And if anyone has
any other business from anyone?
In which case, it just remains for me to say thank you once again to Charlotte and to Kevin, and to wish them the best of luck in their new endeavours, which will be different sorts, of course. But, you know, the future will be as it will be, but the best of luck to both of you. And many, many, many thanks on behalf of the board for everything you've both done for us. So that's the close of this meeting. We'll have a public briefing in July the 13th at, here at St Helier. So who would you like to ask some questions? Right, so we'll go straight here. Thank you.
I wanted to ask a question of Daniel initially on the CQC report, and then I wanted to ask a question of you, Lawrence, in relation to the April 13 meeting. So I can ask Daniel first of all, your CQC report, you highlighted 3 issues. Sorry, the first one that worries me enormously is mandatory training, and the absence of mandatory training. And what I would like to add to this is, I don't understand how you can be efficient. This is a management failing of enormous proportions, because all the buildings and all the rest of it are only predicated on trained, equipped, and properly monitored staff. So surely that's the #1 priority. I mean, sorry, forgive me, I'll go to the next one, if we take them both. You refer to here, you're spending 50 million on land and buildings, which is fine, we know that. And I think you also said 12 is being spent on the estate here at the moment. How is the balance of the 38 to be split between Epsom and St Helier?
Okay, so do the estates one first. So the 12 million is one specific project, which is what you can kind of now hear. Which is the B and C block restoration. There's millions and millions and millions more pounds being spent at St Helier on top of that this year. So the 50 million is across the 2 sites. And do you know the answer to that? My guess is it's about 1/3 Epsom and 2/3 St Hellier for this year, but we could confirm that.
Yeah, I don't have the full figures, but I think you're roughly about right on that, exactly.
So it's about 13 on Epsom, 36 or whatever
But some of it's quite hard to answer because some of the investment is cross-site. So of the 50 million, some of it is on IT, that's both sites at the same time, and some of it is on equipment, that's often for both sites at the same time too. So one of the things we've approved equipment for is to replace anaesthetic machines in theatres.
Okay,
so
it's not 50-50 though, is it?
No, and it never will be 50-50 because the estate's needs on this site are bigger than they are at Epsom.
I absolutely accept that. So I'm just trying to get a feel for it.
The other observation I would make, and Rakesh and Trevor can comment on this, is it's not easy just to look at 1 year in isolation, because obviously there was a very significant commencement of the refurbishment programme last year, and so in a way one has to look at a refurbishment programme in the round, albeit that it's spread over at least 18 months to 2 years.
I appreciate that. Thank you for that.
So
can we part that one?
Yeah. So the training one. So I think we agree that we need to do more on our mandatory training. Part of the issue we have is we set ourselves the most challenging target for the percentage of staff having all of their mandatory training done at 95%. And one of the things we've done in response to what the CQC have said is we've looked at the rates that other trusts around us and trusts that are rated outstanding have given. And there is one trust which is outstanding, which has got a training rate of 80%. And if we had set that as our trust rate, we would have achieved it.
Oh, so you've been measured against your standard?
Yeah.
Forgive me. In that case, I'm perhaps so if you've got the standard,
we would. Part of the conversation. No. But it's really important because part of the conversation we need to have is: do we need to adjust our 95%? But actually, we also need to have it in the context of you do actually want to get to that achievement because that would make you the safest you could possibly
I'd forgotten that
be.
you're trying to climb Everest.
Yeah.
And in fact, if you settle with Bunny Nevis, you'll be fine.
Yeah. But there is more to do, and we know there is more to do.
Right, thank you. Can I ask the next question, Lawrence, please? I was present at your meeting on the 30th of April when you announced this land sale at Epsom Hospital. it was announced that 20% or give or take of the estate would be sold, and you said, or Daniel said in response to my question, that all it needed was appropriate consents from the authorities, NHS England, or whoever it was at the time, the ultimate arbiter. How's that consent been given?
The process is still ongoing, as far as I'm aware, but I'll ask Trevor to clarify that. As you know, we put the land on the public register, first of all, and that means that any public authority has, if you like, first refusal on it. I'm not quite sure whether that period's closed.
No, the period's not closed. The period doesn't close until the 4th of July.
Can I ask the next question related to this then? Assume, I don't know when it closes, I think
4th of July.
4th of July, thank you. When will it then actually transact as a potential, is it 3 months down the line, or a month, or how is it?
Well, it's partly going to depend on the responses that we get to the public register.
You'll have to go through the public register.
And I can't say when it will transact, because just like any property transaction, you just can't tell. I'm hoping, or I'm assuming, that if we get interest from the public sector, then they will be in a position to move and do that purchase within the financial year. Trevor?
So I think whether it's a public sector purchase or we go out to the open market, one of the key issues is that we have to go through several stages with our regulator, NHS Improvement, and I think the earliest will be in the last quarter of the financial year before we'll be able to actually have a purchase that we could complete with.
Thank you for that. And one other thing, I don't know if the board's aware of this or not, but there's a very interesting report in the Epsom Guardian of yesterday, where the whole of the Epsom Council has completed post and sandbagging. So there is a major issue brewing. But I know you've told me you don't have to listen to everybody, so you know that was crystal
We do a lot of listening, actually.
Yeah, forgive me, that was very crystal. It was very crystal clear.
Because that will also have an impact on any planning application
I was aware that the council, in its communities committee, took a position paper, and I've read the paper. I've read, so fully aware of it. I'm also completely aware that we have had conversations with the planning people in Epsom Council about the land sale as well, and planning and councillors' business are entirely separate things necessarily to avoid conflicts of interest. So.
I think it's an important point that the Trust is aware of, and that's what I'm trying to say, because there is a lot of issue around this whole thing at the moment. And forgive me for raising it.
No, we are aware. I'm going to dot to the back, and then I'll come back to the front.
Okay.
So,
Really?
yeah.
Okay. Yeah, I was interested in Ruth and Charlotte's visit to A3, about how lovely they thought it was, because I've had to spend time in there this week trying to get my elderly friend sorted out with access to food and water, which is really quite basic stuff. She had been in, she's been in hospital quite a lot and she's never had a complaint really. But she'd just been home from hospital and immediately broke her hip and back hip. So Monday morning she's very upset because she hadn't been given her, she was upset because she hadn't been given her medicine in time to stop her food harming her. But she hadn't been able to reach things properly anyway. She's had a stroke before. She's got a weak hand, so she can't lift herself up. She couldn't reach her water, can't help herself to have food, and quite frankly, no one was helping her. So I had to come in and try and sort this out. The nurse was rude to her in front of me. She'd been sickle down herself, and the nurse hadn't bothered to get paper towels to help her out before she could get her bowl, which she left her sitting there covered in sick for some time. And when Joan complained about it, the nurse was rude. But the doctor did sort this out. But what I'm worried about is that not everybody has someone to fight for them. You know, I've been lucky enough not to have to be in hospital for some years now. But the times when I've been in here and I've had to help other patients with feeding, get them their cup of tea, put them to their lips because they couldn't do it themselves and there was nobody to help, I thought all this stuff was over. Yeah, because, you know, but it's clearly still a problem. What I'm worried about is when all these people have these individual rooms, there won't be other people able to see that there's a problem. You see, I mean, the amount of times I've, as another patient in the next bed, helped somebody else or because a patient has soiled themselves and the nurse has said, oh, there's nothing wrong with them, they've just got dementia, they're just falling out for no reason. So they're ignoring that patient, and I'm worried what people will do. There's no next bed for them for someone to help.
Yeah. So let me come and talk to you afterwards, if that's all right, and we'll find out what actually happened on Monday, and also how we can try and help get your relative.
I'm every morning now to see if she can reach her water and food.
Oh.
If she's been sitting up enough to, because she can't actually
Yeah.
eat. Various. We'll talk about that a bit later. But it shouldn't have to happen.
You're right, it shouldn't do, absolutely, and that's why Arlene mentioned earlier about we try and make our ward sisters supernumerary as much as possible so they can actually observe what's going on with the wards. So I'm really sorry that your friend and you have been clearly very distressed by that. There are systems and processes when you have single rooms, which we don't have at the moment, obviously, because we don't have enough single rooms. But if we move to them, whereby you do what we call intentional rounding, where somebody's rounding constantly, they're just walking round and round. It's what I did when I trained to be a nurse, and it's what we're probably going to have to bring back in the future, actually. So there are systems and processes about how you nurse single rooms. But
when dealing with an attitude
the attitude is not acceptable, absolutely not, and that was certainly not our experience today, so I'm really sorry you had that. Yeah.
But when if you've got a nurse doing this rounding who quite frankly doesn't care.
Yeah. Well, that's for us.
Patients to suffer.
And we have to handle that.
Yeah, and Charlotte will follow that up with you afterwards. We go there.
You're pushing ahead with plans to potentially remove vital acute services by 2020 from both Epsom and St Helier sites. If you do raise the money for a new single facility, there will be at least a 4-year gap with no services in the area at all. With over 100,000 extra deaths in the UK unnecessarily since in the last 8 years because of cuts like these, how can you all live with yourselves knowing that these plans will result in many more deaths? You need to scrap your planned consultation and put an end to these dangerous proposals.
Well, there won't be a gap, I can assure you of that. I mean, it will take time. Were there to be a new hospital, it would take time, obviously, to design it and build it, during which time everything will continue as is. So there won't be a gap in coverage of acute services. And I think, so that wouldn't happen. In terms of the process, I think we have taken a huge amount of care and attention in the plans we have drawn up, but it is now being moved over to the commissioners, to the CCGs in their meeting next week, to decide whether or not this should be taken forward, because of course, as I'm sure you know, healthcare has been essentially devolved to the commissioners. So the commissioners will take a decision as to whether or not to push forward to the next stage. You've heard a lot today about the challenges of our estate and our the fact that we operate on acute services on 2 sites. We as a board believe that what we have proposed is the right answer in the best interests of the people of South West London and Epsom for the next 25 years. We absolutely understand that these are very controversial issues, but we do believe that these are the ways forward. But as I say, it's now over to the CCGs to decide the next steps. Do you want to add anything? Thank you.
On that same issue, I'm very much aware that St George's is using Epsom General a great deal for all its orthopaedics because it's just failing. And this seems to be their policy. Now, if facilities are going to go here while these proposed 5-year plans are going on, it's going to be even more of a strain. Is there any proposal to sell off land at Epsom General so that will no longer function?
Hang on, we can do this.
All right.
So let me just say, Swelliog is a fixed point.
Sorry?
The orthopaedic centre at Epsom
It's fixed.
It's a fixed point. It is brilliant. Let's.
I know it is.
Let-
Everybody says it. But
Yes,
because
so-
George's is failing.
No, it's not because George's is failing. So let's get James to explain why it's the right thing for patients to have all the orthopaedics consolidated in one place in South West London.
So St Helier provides elective orthopaedic surgery for South West London. And St Helier has been a huge success story. So St Helier is South West London Elective Orthopaedic Centre, and that's the orthopaedic centre based at Epsom Hospital. And surgeons from the hospitals at St George's, at Epsom St Helier, at Kingston and at Croydon come to do some of their planned surgery at the Elective Orthopaedic Centre. And I think that's what you're referring to in terms of some of the operations from St George's that are being performed there. And I don't think there has been any fundamental change in the types of patients that are coming from St George's to have operations there. But what we know is that by bringing together dedicated teams at that single site at the Elective Orthopaedic Centre in purpose-built accommodation with therapists who are totally focused on the recovery of patients after planned surgery, we have some of the best outcomes in the country and in Europe. So it's absolutely a service that we want to promote and we're very proud of. Absolutely.
So how is all this selling off of the land and the plans proposed going to enable that to continue and many of the other good services in this?
So nothing is going to change with the Elective Orthopaedic Centre other than I expect that the amount of work going through the centre will increase.
So the land that we would like to sell at Epsom is land we're not using for delivering healthcare from. So it's surplus land, yes. And the building that St Helier is in is absolutely not surplus. It's a great building.
It won't be affected. Final question, thank you.
Yeah, it goes back to who actually owns the land these hospitals are on. This one, I'm talking about the freehold.
So at Epsom we own the freehold. And at Epsom it's Epsom and St Helier. There's some of the buildings there's a very complicated lease with a charity. The land that we're saying is surplus is not anything to do with the land that involved the lease with the charity. And on this site, it's a mixed site where we own some of the freehold and Sutton Council have a leasehold, or with the lease. So in the 1930s, the London Borough of Sutton didn't exist, and it was London County Council. Then we had this thing when the boroughs were created. Who is the lease? Who are we leasing the land from? And in the end, it is concluded it is the London Borough of Sutton.
Dave, final question.
Thank you. I have three questions. First question. Thank you, Pat, for the question. The point you raised about the cladding. I wanted to ask if the detail of the report is going to be published online or publicly, because it sounds like it's something that sort of should be published. Secondly, my apologies, I missed the very beginning of the meeting, but with regard to Dr. Elliott's appointment, could you explain what Dr. Elliott's role will be and tell us who used to occupy that role or if it's a new role? And thirdly, I'd noticed that I had an email come through at 9:32 this morning while I was in this meeting, announcing the establishment of Improving Healthcare Together 2020 to 2030, NHS Surrey Downs, Sutton and Merton Clinical Commissioning Groups, embargoed until 10 a.m. today. That appears to be the establishment of a very important group, which, as you've mentioned today, are going to be meeting in 6 days' time. Now, the matter that they are going to be discussing is of enormous importance. Does the board think that 6 days' notice is adequate for the public to be aware of such a momentous thing taking place that's going to affect well over 500,000 people, 500,000 people who are your patients? Do you think that 6 days is adequate, and can you tell me what steps are being taken to publicise the event?
Well, I'm going to start on the first 2 points. on the cladding and the fire report, I'm not sure whether it's a public document. Is it a public document, Trevor?
It's not a public document, but I don't see a problem with us actually issuing part of a report. I need to get their permission, but I can't see a problem in that.
Okay. So, and on Dr. Elliott's appointment, because we decided that because we as an organisation are taking on a new area, which we haven't done before, of community work, essentially, and working with the community, both in Surrey Downs with the IDEA system and in Sutton Health and Care, where we will be taking on a significant number of people who work in primary care and in community care, that historically our board has been very focused on acute care. We're taking on a community role. We needed to have somebody as a non-exec, as an associate non-exec, who understood the community side of life better than we do on the acute side of life. So we decided that we would try to recruit a GP or a recently retired GP. We had an open competition. There were a number of applicants. We had an interview process. Dr. Elliott, as a retired GP, was selected. On the other question of the notice, I'm going to hand that on to Daniel because it isn't us it's not us who's doing this, but yeah.
I'm seeking your opinion on whether or not you thought that was adequate for such an important.
So the CCGs are leading the process. They have been engaging people for the last few months in terms of telling people they're setting up this programme. And if you had come to the stakeholder group which you were invited to earlier in the week that David behind you chairs, I think you would have had more notice that the date was coming because it was discussed. The councils certainly know about it because they've been involved in the conversations about getting this committees in common set up. Health Watchers absolutely know about it. So the papers, they have done what they do according to their rules, which is publish them 7 days in advance of a meeting. They've acted within accordance with their rules. They've briefed the media. I'm sure the media will pick it up, and I'm sure that will help encourage people to come to their meeting. And anything you can do in COSH to bring people to their meeting next week, I'm sure will be a good thing. You are right, it's a really important meeting. And I'm hoping that it's going to start off the next phase of the process by which we can secure a huge amount of money to build a set of hospital facilities that we can all be really proud of providing care in. So this is a really positive step forward.
That is a positive spin to put on it, but I've just read the document and it makes it quite clear that there are no circumstances going forward where there will be, as we have now, the 2 acute sites in our catchment. There will definitely only be 1 according to that plan. So I appreciate that you're putting a positive spin on that, but I think the public need to be made aware that at best they will have 1 acute facility instead of the 2 that we currently benefit from.
Is this a public meeting?
Yes, so that's clearly your point of view, which we have rehearsed many times. You know that we don't agree with that point of view, and now is probably not the time to rehearse the conversation again.
But I would certainly encourage people to go to the meeting next week and make a point of view. So I'm very conscious of time and we're over. I'll just take the final one
Can
from
I
the
just
back.
make one point? I went to a Sutton local committee meeting recently, a couple of weeks ago, and what concerns me greatly is communication, because there was a councillor there who wanted to make a point to Sutton Health and Care. He had a very important point he wanted to make. He said, I know of 3 different boards or committees that meet that deal with Sutton Health and Care. I don't know when their next meeting. I don't know who to talk to. There is such a fragmentation going on, an overlap, that nobody knows. So things are rushing through. I mean, I would like to ask what IDEA is. I don't know what it is. I'd like to ask if this is now an integrated care system and we're actually developing an accountable care organisation with its new name. But there isn't time.
Well, so why don't we
we can talk all about that next time.
Why don't we take the feedback and why don't we do a proper briefing on how we are joining up what was something very fragmented into something which is much more seamless and joined up for patients across the whole geography that we. Yes, and we'll explain it in nice. We'll get Chris to explain it in nice, simple language. There we go, Chris. There's your challenge.
Right. Thank you all very much. we're done for today.